binding will not take place. So this is the final step that is required for the platelet to aggregate together. Okay? So in usual case, the conformation is not in activated form. So this is the conformation. It looks like this. So once the platelet is activated, we are going to release all these chemical mediators, and these chemical mediators will then activate the glycoprotein receptors. So once it's activated, it is able to receive the substrate. So for this case, the substrate, they will bind them together with the fibrinogen. Fibrinogen is found where? Where fibrinogen is found? In that region as well. Okay? And when clotting is happening, fibrinogen will be cut down into fibrinogen. Okay? So you find the fibrinogen, that the fibrinogen can be used to also activate the platelet. Okay? So two molecules of the platelet akan bind with the help of this one molecule of fibrinogen. So this is the final step, and therefore the group of drugs that we are going to talk about, they are very, very important, because no matter what happens before this, if this final step is blocked, you block the process. So they are quite powerful or important drugs. So the mechanism of action is very straightforward. They just prevent the binding of fibrinogen. They bind before fibrinogen binds to the receptor, and therefore the fibrinogen cannot bind and cannot attach to platelets together. That's very straightforward. Okay? You can use it for short-term treatment. They are potent. I told you they are very potent because they are basically blocking the final step. So once you block the final step, no matter what happened before that, the aggregation process is blocked. And usually it's given for acute coronary syndrome post-angioplasty. Orang beritakan dia akan letak balloon, dia akan kembangkan balloon tu untuk keluarkan the clot, or they put the stent. Okay, after you put the stent, when the patient is still worried, these are the group of drugs you will give. Okay, so that is what we mean by post-angioplasty. The procedure is called angioplasty. Then we have the first drug, axizimab. This is basically a fragment of monoclonal antibody, and whenever you use monoclonal antibody or antibody derived drugs, this is one of the issues that you will have, the immunogenicity. Okay? So the body will sense this as an alien, and what will happen when the body senses this molecule as alien? Apa yang body kita akan buat? They will form the antibody to go against it. So you cannot use this kind of drugs for long term, okay, because the body will get rid of it. Okay. So you give by injection of IV, the action is also not that long. The adverse effect, bleeding is always there. Okay. Bleeding is forever there. And for this case, you have hypersensitivity due to the immunogenicity problem. Okay. And then you have tirofiban and also actifibratide. Okay. So they are also the antagonists of the receptor. This is a non-peptide antagonist. This is a heptapeptide antagonist. Both of them also binds to the glycoprotein, to the 3A receptor, and therefore they stop. Okay. So this one, there are many new agents coming into the picture for oral. So probably this can be used for those who cannot tolerate clopidogrel and all those other oral drugs. Okay. Now one of the issues with clopidogrel is, apa tahu isu dengan mengenai clopidogrel? I tak bagi nama because I know none of you will know. The issue with clopidogrel is the metabolism required for its activation. It has to be activated. Okay, to be activated, it needs this CYP enzyme. Okay, so CYP enzyme is found in the. Kalau nak kita jumpa CYP enzyme, liver. Okay, now the problem with CYP enzyme. Can someone name me what is the usual problem that arises with this CYP enzyme? Other than drug interaction. different variety of the enzymes because of mutations or whatnot. So, and these kind of genetically related issues are very common, especially also in Asian population among different races. Kita punya susceptibility or kita punya response towards clopidogrel or clopidogrel related drugs yang perlukan SIG enzyme is different. Okay. So we need to say one population will respond to clopidogrel better than the other population. So for this kind of groups, this will be something good as an option. Kalau dia orang tak respons dekat clopidogrel, they can use other drugs yang orally available. So this is to summarize the antiplatelet drugs in the lecture. So you have the tissue factor. Tissue factor is related dengan anticoagulant, if you can remember that. Then you have the one-wheel brand factor. You have the exposed collagen. These are the two things that will bind to the glycoprotein on the surface of the platelet that will activate that will initiate the first process, and after that it will involve a lot of mediators and also binding of platelets, other platelets. So your drug can work at any of these pathways or mechanisms. Okay, so the PAH1 inhibitors basically they inhibit the PAH1 so that the thrombin cannot seize there. So the activation of platelet due to thrombin is blocked. Then you have the ADP. Okay, the ADP binding also is blocked by all these thymoglobulin group of drugs. Then you have the 2B3A antagonist is the final process. You can also block that. You have the thromboxane. Your aspirin is working there. So these are the different mechanisms whereby you can attack or you can reduce the platelet. So faham? Tak faham pun dia tak faham juga, okay? So we are not going to pick up this one today. So we will go to the next topic, the thrombolytics. Okay. So the early lecture yang kita telah bincangkan setakat ini, the anticoagulant and antiplatelet, this is to prevent clotting from happening. Okay, all this pathological clotting from happening. Okay, so we are going to prevent that. But what we are going to use when there is a clot? Okay, you want to prevent, yes, but sometimes probably maybe patient is, patient is a drug or things like that. When the clot happens, in this case, what group of drug you want to use? When the clot is already there, you cannot use. You cannot use antiplatelet or anticoagulant to get rid of them. It's very difficult. So this is a group of drugs that will be used. Okay, so the nama pun lytic means you lyse the thrombus. So when the clot is formed, that is known as thrombus. So you lyse the thrombus and you what we call that. You will basically return the circulation back to the normal condition. Okay. So this is a bit complex. Okay, so just follow me. Right? So first of all, when the coagulation is activated, now this is how our body is designed. As I said, there's no other machine in the world that can replace our body. We are designed in such a fantastic way that nothing can replace us. So in our body, when the I'm not recorded here. Okay, so when everybody is taking a photo, right? This is not in your lecture notes, right? Ada kan? Ada. Okay. So when the coagulation is taking place, when the body senses that something is wrong, and the body feels like okay, it is acting in such an inappropriate way, this system is also set in motion. That means when the coagulation is happening, the thrombolytic system is activated. Just prepare as it. Okay. What is the purpose of this? The purpose of this is if there's overcoagulation is taking place, this thrombolytic system will dissolve them. Okay. So they are already there. They are already there. And this system is this endothelial cell, the cell that's lining blood vessel, basically they release what is known as tissue plasminogen activator. Now this tissue plasminogen activator akan ada siap-siap dekat situ, dekat tempat where clotting is taking place. Now if they sense, if the body sense that the clotting is happening, inappropriately, this TPA will convert plasminogen. Plasminogen is also found at the area where the clotting is happening. Semua dekat situ je. Okay? So TPA akan convert plasminogen to plasmin, and plasmin is a trypsin-like. Trypsin apa? Pernah dengar trypsin? Apa tu trypsin? Trypsin. Amino acid. You make my biochemistry also very wire. No, trypsin is not amino acid. Trypsin is enzyme. Dia enzyme dia suka makan. He will just chop down the bonds. Okay, he like to chop down the bonds. Okay, so he will break down the fibrin. They can chop down the fibrin. Once fibrin is being chopped down, then what will happen is the clot is not stable there anymore, and therefore the clot will just disperse. Okay. So that is the function of this tissue plasminogen activator. Now the activity is localized in the clot region. Okay. Now any plasmin, bila dia keluarkan plasmin, any plasmin that escapes to circulation is inactivated immediately. Okay. And this TPA system basically targets pathological rather than physiological clots. So this is what is happening in usual cases. Okay. So my question is, if our body already has TPA, why do we need drugs? Why do we need drugs? If you already have this system is already there, why do we need drugs? I've already explained this earlier. Whatever it is, whatever produced by our body, the short half-life. Okay, this is one of the reasons. The half-life is very short, and therefore you cannot get the effect anymore. So that's why we use drugs. Okay, so this is to summarize what I mentioned just now. So here, clotting is taking place. Okay, the mechanism is fibrin mechanism and also platelet mechanism. This is here. Now, once the endothelial cell, this is the endothelial cell, the most outer layer of not the most outer layer, the most inner layer that is having direct contact with the blood. That is the endothelial, dalam, bukan luar. The cells will release TPA. Okay. So this TPA will linger around in the clot region, and what they will do is they will bind to plasminogen. Once they bind to plasminogen, they will liberate. Dia akan bebaskan plasmin, and plasmin akan chop down the fibrin. Okay, so this is the simple concept that is happening in our body, and we are using this concept to design the drug. Okay. So we have a few drugs here. So all these drugs basically they increase the fibrinolysis. They increase the lysis of the fibrin so that the clot will not be there. Now this group of drugs, they are called life-saving drugs. Okay, because when the patient is having myocardial infarction or whatever, within certain window period, within 4 to 6 hours, or they have the window period, I'm not sure what is the exact time frame. Within that time frame, if you were to deliver this drug, you can save the patient from having stroke or whatever. Okay, you can save the patient. So these are relatively important life-saving drugs. Okay? So you have streptokinase, urokinase, and all these things. You will have a look at it. So these are basically treatment. It's no longer prevention. This one is basically treatment, life-saving treatment to prevent the occurrence of infarction or stroke and whatnot. Okay. So plasminogen will be converted into plasmin. So what this group of drug does is either they behave like that, okay? Either they behave, or either they convert the plasminogen into plasmin, or they themselves activate the plasmin, and therefore you can have the degradation product. This aminocaprylic acid is actually the inhibitor. So usually when you see all these anticoagulants drugs or have the inhibitors ready, and most of the time this aminoglycolic acid will be used if there's an overdose of the thrombolytic drugs. Okay. So kita akan ada that in our hospital. Okay. So kadang-kadang when you give these thrombolytic drugs, if you give excessively, you need to reverse it back by using aminoglycolic acid. So you have a choice there. So the first one is streptokinase. It's produced by this bacteria. Okay. So this is not an enzyme. Okay. This streptokinase, walaupun nama dia kinase, is not an enzyme, but it forms a stable complex with plasminogen once. So in this case, kita tak perlu TPA lagi. Okay. In the normal scenario, TPA must bind to plasminogen and convert it into plasmin. Kan? In this case, this streptokinase will complex with the plasminogen and change it to plasmin. So we do not need the okay. And therefore, we can also have the effect similar to TPA. Okay. So we activate the plasminogen similar to TPA, but now this is something that is not produced by the body. Okay. So they don't work exactly like how TPA is working. They are less specific than TPA. They can also target plasminogen that is not bound to fibrin. Okay. Maksudnya dia boleh dibebaskan dalam darah dan dia boleh juga kacau tempat lain. Is it good or not good? Definitely not good because it's going to disturb other system. Okay. So this is how it works. Okay. In the normal scenario, TPA akan bind to plasminogen dan akan liberate the plasmid. So in this case, streptokinase will form the complex dengan plasminogen and liberate the plasmid. Okay. So they act like TPA. Then this is just the kinetics. So all these drugs usually you will give parenteral IV or infusion. Its action can be blocked by antibody because this is something produced by the bacteria. So you may have some interaction there. The adverse effects you see bleeding and also allergic reaction for anaphylaxis is common because of the interaction between the antibody and the drug. Then we have an improved version. This is a preformed plasminogen streptokinase complex that is more fibrin specific. So usually if you see drugs, when the first drug comes in, then when people start to use the drug, they will come up with or they will realize what are the actual or the common problem with the drug, and then they will try to improve by coming out with another drug. So this is the usual case. These kind of things usually they don't pick up during the clinical trials. Okay. So that's why clinical trial ada berapa fasa? 4. So these things will happen in which phase? Jadi ada kata 3. Except where you punya knowledge on clinical trial. Clinical trial first tu kita buat apa? First phase. First phase kita buat apa? Do we deal with patient in the first phase? No. Do we deal with human in the first phase? No. Unfair. First phase tak pakai human. Healthy good human, we use human. Kalau dalam clinical trial memang pakai human. Kalau fasa yang kita tak pakai human, fasa yang kita pakai animal, kita namakan pre-clinical. Kalau asyik aku dah bawa. So during the first phase, you will use healthy subjects and you are not testing the efficacy of the drug. First phase, we don't test efficacy. First phase clinical trial, we test the pharmacokinetic and safety of the drug. Okay. In normal subject, we don't use patient. In normal subject. Kalau katakan drug untuk hypertension punya what you call indication, we don't use hypertensive punya patient, we use normal subject. If introduced, then we go to phase 2. Phase 2 is the phase where you use the patient. Okay? And usually it's a single center, small population. And then you have the phase 3 where you do a multi-center, random trials and so on. And then you combine everything. Bila dia dapat tu, the drug company will get the approval to market the drug. Now, drug companies can also be very, what you call, secretive about their findings. They pandai, okay? Don't think that the pharmaceutical companies are all very good. Semua pun penjaya besar nomor satu dunia, okay? So basically what they do is they hide all this toxicity that they find. Usually that's the case. So they don't report that. Siapa yang report? You spend like 20 billion, 30 billion, and then you found this drug, okay, and suddenly it goes into the clinical trial, and then you find something, you report that, and then the FDA or the Ministry of Health say, no, you cannot market this. So you waste all the money. So kadang-kadang dia takkan bagi tahu. Okay? So what will happen is when people start to use, you cannot hide it anymore. When people start to use, when the population start to use, of course they will have the adverse effects. Kalau it's a very common adverse effect, definitely people will find out about it. And then, so this is where you will do a post-marketing punya study where they pick up all these toxicity and report. So this is where people will start to come out with an improved version. Okay. Kadang-kadang dia buat, dia akan improve the formulation. Kadang-kadang if they take the molecule, the chemistry lah, the molecule, and then they change certain part of it to make it better and so on. So this is how they got it. Then you have urokinase. For the first time in the history of humankind, kita dapat drug daripada kita punya urine sendiri. Okay? So this urokinase it directly activates plasminogen. Dia tak perlu form complex or what. It directly activates plasminogen. Also not fibrin specific. Because it is human derived, itu tak ada masalah, human immune response untuk drug ini. Then we have alteplase. So this, the drug yang explained sebelum ini, they are not TPA. They work like TPA, but they are not TPA. The drug that I'm going to discuss after this, they are all TPA drugs. Okay, they are recombinant TPAs. Okay. So this is basically a recombinant TPA, single chain recombinant. It is more active on fibrin. So bila you pakai TPA or TPA-like drugs, they are more specific compared to the other drugs. Okay, the earlier drugs, they are not specific. Okay. So these are more clot selective. Also, you give via infusion, okay. And also it's not antigenic, so it doesn't cause any anaphylaxis or whatnot. Okay. So let us watch a video of it. So you see, this is how the tear happens. Okay, and this tear usually happens due to the deposits of the all those lipids or cholesterol or whatnot. Okay, they call it LDL, all those bad cholesterol. Okay, so this is how the rupture takes place. Okay. So once the rupture takes place, the region here, they will start to form clots. Okay. So eventually the clot will grow bigger and bigger and bigger and bigger to the extent that it can actually block the, or it can reduce the blood entrance to the one part of the body. Okay. Imagine this is happening at the heart in your cells. Okay. So you see, okay, the clot now become embolus, it can move, but this region here they are receiving very less amount of blood. Or after the embolus, they don't receive anymore, they start to die. That is what we call as infarction. They are dying. Okay. So when we use the drug, what will happen? Okay. You see inside the clot there is fibrin. This one you already know. So sekarang ni kita akan gunakan drug to chop down the fibrin. Okay. And this has to be done in a very short period of time. You tak boleh tunggu lepas 24 jam baru nak pergi. Tak boleh pergi hospital, pergi kubur. Okay, sebab patient dah mati dah. Okay, so it doesn't work, alright? So what will happen here is he will basically lyse or he will chop down the fibrin and because they call it reperfusion. He will perfuse back this region. But whether the region or whether the cell there can survive or not, it depends on the timing. Kalau you bagi lambat sikit, once the cell die, especially kalau kat brain, the cells die, that's it, you cannot reverse it. Okay, that's why you have stroke-related what we call symptoms that you cannot reverse. Okay? The patient is still alive, but some of the symptoms cannot be reversed. But if it is done immediately, usually you can save the patient. Okay? So this is the mechanism of action of this group of drug. Okay? So we have replace, this kind of drug. That one is single chain, this is double chain. Okay? Activity-wise is similar. Now this one is also a modification of the TPA. This is similar to alteplase, but it has a longer elimination time. Okay, so between them, in terms of efficacy, is almost same. Similar efficacy. Okay, very quickly to anti-thrombolytic. So setiap drug yang kita discuss, when we discuss about anticoagulant, kita ada vitamin K. When we discuss about when we discuss about anti-thrombolytic, we have this tranexamic acid or aminocaproic acid, but usually this is not used in hospital, of course. So we use tranexamic acid. So tadi saya terangkan, kita ada the aminocaproic acid, it will block the conversion of plasminogen to plasmin. So this drug basically also blocks the conversion. Okay? And usually you will use in overdose cases, okay, to reverse that. Okay? So I'm not going to go into details of it. This is a summary of all the drugs that we have discussed so far. So we have anticoagulants, and we have different classes of anticoagulants, the four main ones. Then we have the antiplatelet. Of course, this is not the complete list. We have some new drugs there, and we have the thrombolytics as well. Alright. So now we can start for quiz. It's just going to be 10 MCQ. Teramat mudah. Okay. Kalau so we are expecting to do it online. Okay. Kita ada perbezaan apa called generation gap. I'm not into all these computer stuff, so I still prefer
We ada minat je.
okay, it's only going to be only for 10 minutes. Okay, I know you all in this class kan. 10 minutes, once you finish it, 10 minutes to eat and then you can go on. Okay, so you